Are we all set, Dave?
Yep.
Okay. So welcome to the Wednesday, January 20th, Littleton Board of Health meeting. So I'll just read the Zoom instructions. The town of Littleton began conducting remote participation / Zoom meetings pursuant to Governor Baker's emergency order suspending certain provisions of the open meeting law on March 19th, 2020. Since that time, unanticipated legal concerns related to the open meeting law have been brought to our attention by the town clerk. Those concerns were supported by the Attorney General's office and confirmed by town council. One concern is that the chat function allows a parallel text conversation to the board's public meeting. Chat is essentially running commentary that is occurring, but is not moderated or followed by the chair. All participants and listeners may not be aware of comments being made because some meeting participants join by phone and do not see these conversations. Another concern is conversations between, oh geez, what's going on? I'm upside down?
You're upside down.
I don't know what I did wrong. You're just going to have to deal with it. Another concern is conversations between residents within the chat room, which are not incorporated into the public record. In response to these concerns, the town will implement, I'll turn that off. In response to these concerns, the town will implement the following changes, which in no way prohibit any member of the public from participating in discussions and sharing information during the public meeting, and will ensure that all listeners and participants have equal access to this meeting. People that join the Zoom meeting are set so their microphones are muted. If you call in by phone, please use *6 to mute or unmute your phone so that the meeting can occur in an orderly fashion. We ask that people who join keep their microphones on mute so background noises do not interfere with the meeting. If you wish to participate in the meeting, please use the raise your hand function available on Zoom, or if you've called in by phone, dial *9. Which will activate the raise your hand function. The meeting host will notify the chairperson of the raised hands, and the chairperson will determine whether and when to allow public comment. When called upon, participants should unmute, then state their name and address. After speaking, we request the participant return the microphone back to mute. So I'm going to turn this back on, see if I can get on the right way. Here we go. So, guys, Janet's a little under the weather tonight, so she's not going to be here. So, Dave, will you help with the hands raised, comments, things like that? Thanks, I appreciate
Absolutely.
it. All right, so we're going to have a COVID update, but first, just wanted to say thanks to Jim Gareffi and the Neshoba Board of Health for holding the first responders vaccine clinic at the Boxborough Host today. So. Kirby sent me some pictures. Maybe we should distribute those if you want. I guess it's on YouTube, but Jim, take it away.
Thank you, Lisa.
Oh, thank you.
So we did have the clinic today. There was lots and lots of people who were involved. We kind of set things up so we could get it going. Since we have the vaccine registration through the state, lots and lots of volunteers. Littleton Volunteer Corps was there. The Boxborough Emergency Reserve Corps was there. We had school nurses who volunteered, but members of other boards of health who are nurses and could help us vaccinate. So lots and lots of people. It went extremely smooth. We probably could have put, I don't know, half again as many people through it without an issue. So we were really happy. It's the first time we used this vaccine. Probably the most anxious part of it is making sure you don't waste any at the end, making sure that you actually wind the doses down to the right amount so that you have them all in arms before you leave. We were able to accomplish that, so we were pretty happy about that. The rest of it is just a clinic setup. It is a little different in that the vaccine manufacturer asks that people sit 15 minutes or 30 minutes, depending if they have particular health conditions, after they're vaccinated before they leave the clinic. And again, we were a little concerned that maybe people wouldn't be compliant with that, but most people came, sat, they had their electronic device, they tuned out for a bit. Sometimes people were sitting there longer. I don't know if they just kind of got into whatever they were doing. So, but it went extremely well. I'm really quite happy with how that went. We are doing our second day of the first responder clinic on Saturday at the same location, and we will have all the help we needed again from all of those groups. So again, lots and lots. And the Boxborough Regency, I don't know if the general manager was just sensing that we needed a spot for it, but the day before the state asked us, she had reached out and said, hey, if you need a clinic location, we're happy to do it again, because they had hosted Boxborough's flu clinic there. They have a nice big room. It's, I don't know, it's 70 by 90, big wide open room. So we were able to do all of the stuff we needed to do, socially distanced, queue lines, table set up. So it worked out really well. I'm really happy with the way it worked out.
Did they donate the space?
Beg your pardon?
Did they donate the space?
They did.
Awesome.
Yeah.
So nice.
Yeah, just a great corporate citizen, just great corporate citizen. I couldn't say enough.
Great.
Anything, I mean, and I sent them a sketch of how I would like the clinic set up, because I figured they would just point us to the stuff and we'd set it up. But we got there to do the clinic and the physical setup was done according to my sketch, and I just couldn't have asked for more. So it was really very good on their part. Just some conversation about vaccine going forward. There's, I don't know, there's kind of a continuum from anxiety to impatience to, geez, I want this over with now, about getting vaccine. And I understand that because I talk to a number of people every day about when is it our turn. And I think I wish we had the vaccine or access to the vaccine at some regular interval that I could say we could set something up right now. We really can't. We, the Board of Health, need to follow the state's plan. So people are looking to see what the Board of Health's plan is. Board of Health's plan is to work within the state's vaccine rollout plan. The state has 3 phases. Within each phase, they have priority groups. Those are the ones that they want us to be handling. In this case here, they reached out about mid-December and said, hey, can you help us with first responders? And that's why we set that clinic up. There are some other small groups in that. We'll reach out to them, the congregate care settings, group homes, where those healthcare workers. So we'll try to reach out to see if there's people in those categories between now and the start of the second phase. The concern is at the state's level, and they've asked us not to kind of jump the phases, is that they really want everyone in the state doing the same thing. It's a little corrosive if people are just kind of doing what they want with it. And so they really want the rollout to go the way they did. The state's advisory committee put together the plan that the state has up on their website to address, to try to get those people who are first dealing with people who may be sick and to try to protect healthcare workers and to try to limit death from those people who may contract that. So that's really the 2 guiding principles that they've had for the program that they've put forward. I don't know that I wish they had in the public health conversations that I had with Department of Public Health, there's obviously a plan there. They don't have vaccine in-house. They order from the feds ship it to the states, the states distributes it to boards of health. So they do have a plan for ordering, for people who are doing the categories that they have up on their plan. So it's not like we can go buy vaccine and just start our own clinic. We really need to get the vaccine to the state. So what we've been recommending to folks that we talk to is to go to the state's website, so mass.gov /COVID vaccine, and that brings you up to the state's webpage that says, when can I get vaccinated? And on that webpage, you can click around, you can look at what the state's phasing plan is. They kind of will go through the different priority lists, who's in those priority lists, kind of let you know when your eligibility is. There's a chart that shows where the state believes they're at as far as vaccine distribution in those phase groups. Gives you an idea of what timelines you might be looking for depending on what your eligibility group is. And I think that's a really important piece for people to do first, because lots of times people call and say, is it time for me? And it's like, again, particularly with when we start to get into second phase and we're talking about 2 comorbidities, I can have that conversation with people and tell them that that's what it says. But that state chart really kind of will clue them in as to when the state believes they're going to have the vaccine to do those various groups. I think I sent out just kind of a narrative to you, Lisa, that whether you wanted to put it up on the Board of Health webpage or how you want to do that, that kind of goes through these bullets, like go to the state website to take a look, see when your eligibility is, check in with the large pharmacy groups, check in with your own primary care physician. And people should do this as they get close, as they see their eligibility comes up. So if you're in third phase, there's really no sense of you looking at that site yet, because you're probably looking at the spring before the state believes and so the third phase is anybody who doesn't fit in phase 1 or 2, and all of those phases, and essentially it's the general public. But again, if you look at that and then at about that time frame, start looking at the pharmacy sites, start looking at your primary care, that should give you a sense of when people believe they'll have the availability to vaccinate you. We are exploring trying to do a regular clinic weekly, probably a regional effort. We're in talks with the state about it. Again, availability of vaccine is what is really important. We can set up the site. I have probably a couple of sites that are willing to do it for us. I even have a skeleton of nursing crews. I've talked about an idea with a handful of council on agings just to see if it was something that they thought would be possible to work with us to get it done. But what I don't have is the vaccine or a knowledge of when I might get that vaccine. So the sooner I know, then we can actually start pulling triggers to do things and get that information out to people. There is a mass, we all hear about the Gillette site. There's a web address for the Gillette site, and if people want to go to that site, they do the same thing. They're going to check your eligibility first. So you just can't go there to get a vaccine. You need to be in one of the eligibility groups that are ready to be vaccinated. So it's, and I think it's in that note that I sent you, Lisa. So if you want to print that whole thing up there, that link, it's www.cic-health.com/vaccine. And that brings you up to the site and it walks you through eligibility, registration. But again, they're vaccinating, the state is vaccinating according to that plan and providing vaccine to boards of health according to that plan. I don't know if anyone has any questions. That's a lot of information.
Just one question. Jim, will you have enough to do a second dose in a couple of weeks?
So we're told by the state that we'll get second doses automatically. So part of the vaccine so it's new vaccine, new software. So the software is probably more important to us just for a labor saving, because after every clinic, you have to go in and enter everyone's vaccine records. So this software is like a unicorn. It does billing, it does entry of information, data information into the state's vaccine website. It helps us arrange schedules so that we can plan the doses. So the state will know as soon as we push the button on the clinic how many people we vaccinated. And again, that's the information the state uses to be able to provide things like second doses. And we do have the 2 second dose clinics already set up.
Excellent. Very nice. Very good. Anybody have any questions or comments about the?
I just have one question, Jim. There are lots of routes to provide the vaccinations, and it's great that the state is going to hopefully stick by some sort of plan. I'll discuss go into the implications of that quote plan unquote later. But I'm just curious, once we get beyond what we'll call the smaller need to be served population, which includes the group, I guess you call it in phase 1A or phase 1B. Once you get beyond that, you're no longer in the hundreds per site. You're in the couple of thousands per site to become eligible. I'm just talking about the eligibility issue.
Yep.
And from your experience so far, how feasible is what you're doing, or what's the scalability from what you've been able to see in sites other than things like Gillette or other large venues that are not 70 by 90?
So again, what we're kind of exploring next is, what can I pull together for staff? What site can I get, and how frequently can I get vaccine from the state? And so, we're looking at well, I mean, if I don't get vaccine from the state, I can't run a clinic. So, I mean, that's kind of the issue. So,
no, I'm not asking you when to start it. Okay. I'm asking from your experience with the numbers you just handled.
Yep.
How, in your view, is it scalable to the larger numbers that comprise the next, shall we say, priority groups? In other words, I know the vaccine is not, the vaccine is at the moment a rate determining step. The other step is accommodating, delivering the goods, as it were, into the arms.
Sure.
As efficiently and as fast as you can do it. So I'm just asking whether or not your current setups have instructed you or informed you about, how they're going to do it in Gillette, or how would you do it in Gillette, or anywhere, say it was closer to home, somewhere on the point. I'm just making this up.
Sure. So I guess part of it is we hope to be one of many. The state is working with the pharmacies. The Mass Medical Society is working with the doctor's offices to start that process of making sure they can provide it. So you're right. That next group, I think the first group in the second priority, and the first priority and the second phase are those over 75, those with 2 comorbidities. So I assume that's a pretty good size group. And so the site we're looking at maybe we can get something going to start with 300 or 400 people a week. Again, we're planning to be one of many. We're hoping that people can get it where they normally get their vaccines, which is what we health departments were told at the beginning of this.
Okay, and just so you know why I'm asking this question, it wasn't just to test out your organization. It's how long does the population at large, what I mean, everybody other than the first responders.
Yep.
What's the timeline until we have up to or very close to 50% of the population vaccinated? Because that determines what actions will face you and the rest of us in mitigating spread of the virus. This is why I'm asking the question.
Sure, and I couldn't even imagine how I would answer that question.
No, I'm not asking you to.
Okay.
I'm trying to get the pieces necessary.
So I felt pretty good that Gillette did 300, doses their first day when they opened up, and we did 300 doses our day when we first opened up. So, it's
yes.
I think it's this was the first time we did it, so now we know what the staff we knew. We know that we had. We know the timelines it takes to run people through different parts of it. So I think we have a better sense of how to do these now after having done the first one. So hopefully we'll hone that skill. And then again, for us, I'd like to say we could set up a much bigger clinic, but if I can't get the vaccine, then I have to tell people, geez, I can't really do it.
No, I'm not asking you to set up. I'm after just the population, regardless of it's. You've gone as far with this as you can. I got other pieces, but that's okay.
Okay, thank you.
Hey, Jim, this is Gino. I'm sorry I'm a little late. My question is, will the Board of Health will find out when we're going to be able to have the vaccine so we can, the process is, are we going to do everybody in Littleton, or they're going to put it on a pharmacy, or the doctor's going to be able to handle it? But the question, they can only handle it only few people. Wouldn't it be better to do like they do it in Florida, like PJ Polavella was telling us? They also have the National Guard helping, you know what I mean, for the process, because he got up close to 10,000 people in Littleton. Maybe 6,000 people might get the vaccine, and maybe some, they're too young, maybe they don't need it. The question is, we have to accelerate it, like Mike says. If we just delay it, how long would it take before you are able to say the government of Massachusetts has vaccine for us?
So a couple of things, Gino. One is that we have to follow the priority list that the state set down. So we'll have to follow that. So and then the Moderna vaccine, which is what local boards of health have been getting, you can only administer for people 18 and above. It's not, the Pfizer has a little bit of timeline below that. I haven't heard anyone who really says that the way Florida rolled out their vaccine was appropriate, because they've got people waiting in line in the hot sun. And so I don't know that Massachusetts is any better, but I know we don't have just people standing in line who may or may not get a vaccination. So a lot of this, Gino, is really going to be predicated on what the state can do for us. And that's the information we try to get from them weekly.
Yeah, that'd be good, because I belong to Rotary, and Rotary would like to volunteer, not to vaccine anybody, but to the process, to let people coming in and out to get some information, whatever. And if you need Rotary, you can get in touch with me, or you can get in touch with Steve Glide, which is the president of Rotary. And also the district also would like to contribute. So
Yeah.
we trying to get all Littleton, not only Littleton, but in Massachusetts. You know what I mean? There's a district, different district, and the Rotary will be able to help. All you have to do is ask for help.
Okay.
You know what I'm saying?
Yep. No, that's like I say that, if you knew you had the vaccine kind of stocked somewhere, you could make different plans and do things differently.
Right.
Right
Right.
now, it's not stacked anywhere and we're following the state. So,
Yeah. And I hope it will not be later than February. I mean, now it's January almost gone. I'm saying that February is like in a week and a half or so. We need it to be sure. As the governor make the decision, or you people ask for it when I able to have it.
so the as I was saying to the group earlier, the state website for this, where the state's vaccine plan has all the phases set up and all the priority groups set up, and it
I
has a
got it.
timeline at which they believe they can do those things.
I got
So,
it.
the next groups, we're in phase one now. They're figuring that's going to be through the end of January, maybe into the first part of February.
Yeah.
Then phase two will start. And then we'll start to tick off those phases, those priority groups in phase two.
Yeah, if you like Mike made the reference, the point is a big spot, and people with a lot of cards can come, and we can do a lot of people that way with a lot of volunteers. And I understand the governor also will allow the National Guard if you need, you know what I mean, because there's the more people we have to help, the more people get the vaccine, but we have to get the vaccine first.
That's
And
right.
you have to know.
That's kind
you
of the
have to know how
bottleneck
many.
right now. Yep.
Yeah, you have to know how many vaccine are able to, you know what I mean, do the process. We need 6,000 vaccine for Littleton,
So,
or 8,000. Who knows?
so mass vaccinations, for the general public,
Right.
just to kind of manage expectations, according to the state, we're looking at, sometime in the April to June timeframe. So
I got it.
those big clinics,
Yeah.
for the townwide kind of vaccination, they're looking at spring based on the state's plan.
I got it. Thank you so much. I appreciate it. I was wondering if a private doctor like my doctor or the pharmacy right here in Littleton's CVS will have able to have it before March. I was wondering that.
So, and this is again, all of the different vaccine providers need to follow the state's plan. So right now, the CVSs and Walgreens of the world are out helping the federal government do the long-term care facilities.
I got it.
So they're in doing those. It would be my expectation that once they're done that, maybe they're pulling back to the pharmacy, and maybe they can start to make it more available to the next priority group in the next phase when the state allows that.
Okay, beautiful. We thank you for what you're doing, Jimmy, okay?
Okay.
Yeah.
I have a
Thank you,
question for you, Jim.
Sure.
Please go ahead.
With Littleton, the way it's situated with Route 2 and 495, I don't even know if this is possible, but would you think that we could have a vaccination clinic for people just driving by on the highway that, aren't able to go to their town, but, go by Littleton every day? You know what I mean? Like a broader audience?
Mhm.
So I would say when we do flu clinics, we worry less. In a normal year, we worry less about where people live. So this past year, where the high dose vaccine, flu dose, was a little tight, we wanted to make sure that it was going to the residents in your town. But in normal years, where the vaccine is more plentiful, we're less concerned about where somebody lives. And according to the state plan, residency is not necessarily a requirement for getting vaccinated in the state. So
you could do that.
we're nowhere near doing that kind of a clinic at this point.
Yeah.
Not until the springtime, I wouldn't think.
No, right. I'm just thinking down the road when
Yeah.
it opens up more.
Great. Kevin, did you want to ask anything? Okay. All right. Thanks, Jim.
Okay.
Anything else to add to about things been quiet at Market Basket?
Yeah, I mean, it's I've gotten some complaints that people have to stand outside now in line a little bit, so maybe that's a good thing.
We asked them to do that, so.
Yeah. And they certainly make that announcement when they're making their announcements inside, so
It's
they're
not
following
them,
all the
it's us.
rules by the state and the local board of health, so.
Yeah, blame us.
Well,
You don't have to stand outside at Donlands, you walk right in, just
There you
saying.
Shop local.
I've been going to Donlands lately.
And then, just kind of, and I'm sure Katrina, I don't want to steal her thunder. The first part of this week here, we started seeing a trending down of numbers for the district after, the 9th, the readings on the 9th. So we're hoping that continues, although today's numbers that came in for the district seem to bounce up a little bit. So I don't know. I was hoping that maybe we had gotten through the holiday push, but maybe not.
All right.
Thank
And on
you.
that note, segue right into Katrina. Thanks, Jim.
Yep.
Eat your dinner, Jim. Turn off your video. Eat your dinner. Hi,
Jim
Katrina.
definitely earned it.
Yes, he
Nice to
did.
hear about shots going in arms. Hi, everyone.
How are you tonight?
I'm doing okay. How are you?
Good.
All
What you
right.
got for us?
I am assuming you see my slide kit.
Mhm.
Okay, great. So Jim didn't steal my thunder, given that he gives us the data. So the update every week. So that's okay. So we're going to start just as usual with the state data. So this is the front page of the dashboard, and it gives us, I guess it's not the front page. It's the trends, overview trends page of the dashboard. And I've limited the time frame to this time to middle of November through January 16th, because data takes a few days to come in to be complete. So by the 16th, we're saying we should have mostly complete data. And so looking at that period where we expect to have mostly complete data, the trends are actually pretty steady-ish, since Thanksgiving. There was a little peak, of course, after Christmas, but that's kind of looking like it might be turning around, which is nice. And that's for everything. So that's cases seem to be coming down a little bit, test positivity. So the number of people who test positive over the total number of tests seem to be coming down now that the testing has picked back up. Hospitalizations seem to have plateaued, and the deaths seems to have plateaued in the last few days. So these are all like really good signs. Like I said, we had that dip in testing around Christmas and New Year's, but it's picked back up to be about pre-Christmas levels, which is a really nice thing to see. Unfortunately, we just ran into another 3-day holiday weekend. So there'll be a little dip and a little bit of delay in reporting, but it won't be as extensive as we saw between Christmas and New Year's. And then this is the test positivity. So test positivity is the measure of the total number of tests that are positive divided by the total number of tests conducted by the state. And that's number of tests, not people. So this is not a prevalence of disease. This is literally a test metric. So 2 weeks ago, our test positivity coming out of the holidays was 8.3%. And that was probably really impacted by that dip and lowering of testing that was happening, the reduction of tests, so that the people who were seeking testing were more likely to be sick, and that or seeking it for symptoms or close contacts. And that kind of increases your the total number, the percent that are positive. So now that the testing levels have returned to normal over the last 2 weeks, that we're seeing that the test positivity is coming back down some. So it is really nice, given that the holidays, we didn't hit that peak, which was where testing was a little off, and stay steady there. Like we did after Thanksgiving, we've hit a peak where testing was off and we've come back down again. So that's actually a nice change from after Thanksgiving for the period after Christmas and New Year's. So we want to keep it this way if possible. So this is the number of confirmed cases on the top. This is probable cases on the bottom. You can see that the trend line for confirmed cases, you can see the average 7-day average trend. And then behind it, you can see each day the number of cases in each bar that were diagnosed or tested positive that day. So the number of confirmed cases last week was lower than the number of confirmed cases that we saw between Christmas and New Year's. So we hit Christmas and New Year's, we had this like plummeting because there weren't testing happening. The week, 2 weeks after Christmas, the week after Christmas and then New Year's, we've had this increase in the number of cases, but then we've gone back down. You can see this grouping is fewer confirmed cases that occurred in the last week. So that is a nice leveling effect happening. So we're pausing where we are. We're not continuing to rise on that post Christmas and New Year's surge like so many other states are seeing. The 14-day incidence rate went from 61.1 per 100,000 2 weeks ago to 75.5 or 75.5 per 100,000 this week. That actually, so the first week, the measurement, let me repeat, the measurement rate after New Year's was the 61.1. And then last week it was 78 per 100,000. And then this week it's 75.5. So we've actually, you can see it, we've hit a peak and we kind of came back down a little bit. So that is a nice thing to see that. We had a similar thing happen right after Thanksgiving where we hit the peak and we came back down and we stayed steady until we hit Christmas. So the good news is that it appears that we've passed the post-holiday increase at this point and that all metrics are kind of leveling off or maybe even declining a little bit. So that's awesome. So even better news or more encouraging news at this point is that the number of hospitalizations have also declined over the last little bit here, the last week and a half. On January 6th, well, that was 2 weeks ago, we had about 2,300 cases hospitalized each day. That was at its peak. And then now it's closer to 2,100 hospitalized each day. So still a number of people, a good number of people going to the hospital. We're probably not quite post the holiday surge on that, depending on how people, if people got together or whatnot, but it's really nice to see that there was this little dip back down. Hospital capacity is still pretty occupied. There's 86% of hospital beds are occupied and 79% of ICU beds. That's been pretty steady. So that the number of occupied beds hasn't really changed, but the number of people hospitalized day over day seems to have reduced a little bit. And then also the number of deaths appear to be leveling off. We are now averaging about 60 deaths reported each day. While we don't want any deaths, it's kind of nice to see that it's not continuing on that upward trend like we saw after Thanksgiving. So these things combined with the leveling off of the other metrics is really encouraging. And remember that the state did some rollbacks to reduce the pressure on, rollbacks on opening and capacity limits and what they were allowing people to do. So starting right after Christmas, and that's extended through, I think, January 24th, unless he extended it again. So it seems like the combination of things has really helped us to kind of hit a leveling off point. The whole point of the rollbacks was to release some pressure on the healthcare hospitals and healthcare providers. And so it seems like maybe this is an encouraging sign that that actually worked. So if you recall last week, I was a little concerned about some changes in that 0 to 19 age group. So the state has updated the data today, and so I've updated this slide. So on the left side is the chart with the number of confirmed cases by age group reported, and that's updated as of today. So if you remember last week, I was saying there was this 4,000 case jump in the 0 to 19 age group, which was a bigger proportion jump than the other age groups. And I was like, and it was also combined with the test positivity that increased from 16% to 19%, which I was also trending both in the same directions, which was concerning. And I was hoping like that wasn't an ongoing thing. And the nice thing is that there was only 500 additional cases for this age group added this week. So it's not like we went 4,000 and another 4,000. We had just a little bit of a jump up for this age group. And the test positivity for this age group, it also leveled off. So test positivity is pretty level for everyone else. College testing starting to ramp up. So the test positivity for the 20 to 29-year-olds is starting to move a little bit. And it's nice to see the 0 to 19-year-olds didn't continue an increase. So we got to still keep an eye on this as the state starts rolling out the school pilot testing program. But again, like this was something that worried me last week, and I'm more reassured this week that this isn't a continuing trend. It might have just been the holiday increase for this age group. So then we're going to get into the local data. Of course, our lovely color metrics. So Jim released to you guys today the data. I didn't have a chance to look at it for all of the catchment area that Jim serves, that Neshoba Board of Health serves, but I did add Littleton's in today. So if you recall, 2 weeks ago, we had 46 cases. So 2 weeks now is a whole different group of cases, and we have 59 cases. So we're higher than we were 2 weeks ago. However, we are lower than we were last week. So that is also encouraging that Littleton has also maybe hit this leveling off spot that the rest of the state did as well. But this does make us 9 weeks in the red. So we're still in the red here in Littleton. So this is the data as of last Thursday for the town level data. And this is where we look at the average daily incidence rate per 100,000. So we can compare different areas during each 14-day period. So this is the number of cases over population. So the rates through, so the rate for this last week was December 27th to 26th, I'm doing math, to January 9th. So that captured the week right after Christmas and the first week of January. The data that will be released tomorrow will be the first full 2 weeks in January. So the 2nd to the 16th, which will include that pick back up of testing that we've seen across the state. So Littleton's rate last week was 50.5 per 100,000, which was an increase over the prior week. But again, testing's a little off. So I would say we'd probably, if we had real tests, the same level in testing, whatnot, it would probably have just been, now that we know more, it's just kind of a flattening. And then this should flatten off again, given that we had fewer cases than we did last week. So this is the test positivity. So these are the total number of positive tests for Littleton residents over the total number of tests done for Littleton. So, and that's in a 2 week period. So this is the this is last week's town level data. So this captures again, December 26th to January 9th. So in that 2 week period, Littleton had 1,285 tests. That's actually a similar level to the number of tests we had before Christmas, the week before Christmas. And our test positivity was 5.76%. Our rate of increase was much higher than the other areas that we track. So that was something to keep an eye on. It'll be interesting to see what the data looks like tomorrow. But hopefully, given that we had fewer cases, that this will level off as well and still be the same number of tests we're used to seeing. So this is Littleton just week over week, the number of new cases by week since April. And as you can see, when we had the whole shutdowns, we just didn't have that many cases going around. We simmered for a while, and now we've got the most number of cases that we've had. Again, this should dip a little bit because tomorrow when we see the new data. But this does tell me that most of Littleton residents are still susceptible to catching COVID-19. So it's something that, while we, hope we're not like exploding, we're not in a Chelsea kind of situation. It is unfortunate that most of our population is susceptible to getting infections, and we should still be doing everything we can to protect everyone. So other things that have kind of started coming out is now that we are an entire year since the first case was identified in the United States, we're starting to have enough people who've been infected and enough time passed to collect some data on long-term health effects that are not hospitalizations and deaths. So hospitalizations and deaths are really easy to measure. They're pretty clear metrics, which is why we've been using them. It's in part why we're using them. But the thing with COVID is because some of the biological things with the ACE2 receptors and things like that is that it can really get into a lot of body systems. And I know that Mike has touched on this a few weeks ago, but this chart of more common long-term symptoms and such as fatigue, shortness of breath, cough, joint pain, chest pain, the other reported long-term symptoms such as difficulty thinking or concentrating. Some people report brain fog, depression, muscle pain, headache, intermittent fever, and like fast beating hearts. And then more serious long-term complications are also being studied, or like the difficulty thinking or concentrating, cardiovascular inflammation of the heart muscle, respiratory lung function abnormalities, renal acute kidney injuries, rash, hair loss. I've had actually friends who are doctors who lost their taste of smell and it still hasn't returned weeks after they've had recovered from COVID. Sleep issues, difficulty concentrating, memory issues, and some reports of depression, anxiety, and mood changes in mood for people who have recovered, a long time recovered. So some of these symptoms aren't just if you get sick and you're recovered and you're fine. Even people who have not been hospitalized and they've had mild illness can experience and have reported persistent or late symptoms. So that includes young people. So even people who are physically fit and young have been reporting symptoms months after their acute illness has resolved. So there's reason beyond hospitalizations and death to try to control and limit spread of COVID-19, in part because we still are learning about what it's doing to the body and who might be most susceptible, even if you're not older. So this is an important thing just to keep in mind, a reason why you want to do your best you can with all the layers of mitigation and masking and distancing, things like that. So if anyone was at the school committee meeting last week, they started talking about potential of bringing the pilot testing programs to Littleton, whether it's even feasible or possible. So I thought this might be a good opportunity to run through the what are testing programs? Like, let's go through what they actually do and how they help limit transmission in towns. So the first thing to understand is that how COVID transmits, the biology of it. So this is an image that depicts SARS-CoV-2 viral load in relationship to the time since symptom onset. So this teal line is the viral load. You can see that it increases rapidly over the first few days before from exposure. Time zero is when symptoms start to show, and then decrease again. So that's the 14-day incubation period that you're used to hearing about. That's why quarantine was 14 days. So the viral load is related to how contagious someone is. So the higher the load, the more likely it is to be passed along. So an individual, interestingly, is contagious or starts to become contagious in 1 to 2 days before they exhibit symptoms. And those symptoms can appear anytime between 0 and 8, 0 to 8 days. Basically, people between that time is when people will realize they're sick. Another interesting part is that up to 40, it's been reported 20 to 40% of cases don't report any symptoms. They have such mild disease, they may not even realize they're sick, but they still can be passing along COVID to others. And it's been estimated that up to 50% of spread can actually be attributed to the silent transmission. So that spread is happening when in that pre-symptomatic phase before symptoms appear or before people realize they've been sick or exposed. So this is a slide I put together to try to demonstrate what our current testing strategy is in the state. So our current testing strategy for state level is based on symptoms or close contacts. So on this left-hand side, we're talking about what an individual who is symptomatic. And that's really kind of easy. You tell them to go get tested. If they are positive, they're tested positive, and they enter that contact tracing and quarantine system. So they may have already transmitted to somebody and that person's symptomatic or they're pre-symptomatic, but because of the contact tracing and quarantine, that they're kind of isolated quickly and helps to break the further chains of transmission. So current policy, like school policy, indicates that positive cases don't attend in-person school too. So that also, that policy helps to break that chain of transmission in the school setting. So that's another great mitigation strategy. So the testing, so just in general, if you have a symptomatic individual, it's really easy to identify that someone's sick and they might be more likely to infect others around them and to break the chains of transmission through quarantine and contact tracing. So on the right-hand side shows what happens when somebody is pre or asymptomatic. So remember that people can transmit COVID a day or two before they have symptoms, if they ever exhibit symptoms. And so if a person, the original person is pre or asymptomatic, they actually don't get a test, which means they can transmit to other people. And on average, people transmit to 2.5 people. That's the R0 that's currently being estimated. So this person can give it to 2 other people. If the person they transmit to becomes symptomatic, they get caught and there's contact tracing and quarantining. So that chain of transmission is broken. But if that person does not end up getting symptoms, they're actually missed, and that person can end up giving to 2.5 people. Again, if they're symptomatic, it's caught, and if not, it keeps going. So this chain of transmission can keep going if we're not identifying people who may be sick but not exhibiting symptoms yet. So another way that this individual, if we're putting them into a school setting, we have a group of people who are in the same building together, and that there's the potential for pre or asymptomatic spread. And I'm not saying there is transmission in the school, but because we're gathering groups of people together inside for long periods of time, there's potential there for spread. And if that happens, then you have the same looking for symptomatic cases, you'll catch them and get to do contact tracing. But if they're asymptomatic then or pre-symptomatic, you won't, and your chain of transmission can continue. So without a testing program, we really don't know if transmission is or is not happening in schools. Which comes down to what is happening in schools. So there's, I've started going through the literature and I'm still in the middle of it, but I can, in my high level overview, one of the issues that's happening with what we can look at, like in this published studies, is that everyone acknowledges that kids are more likely to be asymptomatic or pre-symptomatic. So they're less likely to be tested with our current symptomatic testing strategies. And that really limits the case identification in school settings and what is reported in these studies. So there's under case ascertainment for these school studies. And in addition, the current close contact definition, which is someone who you've been within 6 feet of for a cumulative 15 minutes for a 24-hour period, really limits who we tell to go seek testing. So distance is one of those things that we know helps to reduce spread. And the close contact definition was created before we knew more about aerosolized spread of COVID in indoor environments. So the contact definition tracing definition is restrictive in terms of trying to figure out if school spread is happening, because we're not asking people to go get tested if they happen to be in the same cohort, for example, as a case. So in addition, most school studies to date are really limited to reporting rates of cases or even just number of cases. There's really no, I haven't seen any study yet which actually did asymptomatic surveillance testing to really get an idea of what's happening in schools. And in addition, hybrid school models can really vary. They're all called hybrid, but they really vary widely from town to town and city to city and state to state. So there's really, each school has done this different, gotten to choose which mitigation strategies they're going to use, like masks and distance and how long people are in the building, ventilation, what they're doing for lunch, how closed they're making the cohorts, which can impact school transmission. And we also lack denominators in most of these studies for how many people are actually in the school. So it's hard to do, so like density of people in the building or in a classroom. So it's really hard to understand what's happening and the risk of transmission among different settings, because every school does it differently. It's even different within the same school or school system. And there's also, I know there's a lot of people who are really trying to get data, like people are trying to do studies on this and doing what they can, but there's some potential selection bias in that school districts who choose to give their data or share their data may actually be motivated differently than those who choose not to participate. And that part of that could be affluence of a town or an area, whether they're public or private, whether they want to have the public scrutiny or not. So there's a whole bunch of reasons why school districts may or may not choose, and that can actually impact the information you're finding in the data that you're collecting. So I think people are trying to do the right thing, but the data is limited. And so what I see as an opportunity is this mass pooled testing pilot will be the first thing I can see coming at us that will be prospectively collected and broadly measure COVID-19 in schools. That have a shared set of mitigation strategies and policies that Littleton has. So this is actually kind of an exciting time to actually really learn what's happening in schools that are doing things similar to like what we are doing. So this is a great step, in my opinion. So knowing all that, let's talk about pooled testing strategies. So on this slide, I've updated the prior slide where I was looking at the chains of transmission, but talking about how pooled testing helps break those chains of transmission. So the pooled testing doesn't actually do anything to a symptomatic testing program. You can keep having that symptomatic testing program happen. You should continue to have the symptomatic testing program happen. And also, if a family member is symptomatic, you want the kid to go get tested outside of your routine testing, your pooled testing. So that should keep going. That shouldn't change at all. So pooled testing, so you would group people together. So I think groups of 10 to 24 is the normal pools. And then you do their swabs, you stick them in the same thing. If that pooled test of 10 to 24 test positive, then you try to break it down to retest each of the individual tests until you would figure out which person is positive. There are systems for that. They differ between the two testing programs that the school is choosing. So I'm not going to go into specifics about that. That is for the schools to look at, but the goal is to get down to the individual who tests positive. And from there, once you have a positive individual, you'll get to go into the contact tracing and quarantine setting, so which breaks those downward line chains of transmission. These don't have a chance to happen. You've caught a case before they knew they were symptomatic, and you caught it early enough to break downward spread of the disease. And also, since it's in a school setting, you get to remove that person from the in-person setting. They still get to have remote school if they're feeling well enough to attend, but that person is not in the school to then potentially spread to others in the school. So that helps, again, break that chain of transmission. So overall, the school testing program would have impact on helping us understand what's happening inside the school and whether transmission is happening. Or our mitigation efforts, all those layers of mitigation that we put in place, really helping. But it also helps prevent, if you think of, household spread. So if you identify a kid who's positive, there's probably another positive individual back at home, and that family can then quarantine, isolate, and get tested so that they can not spread to others as well. So this has a real impact on the community as well outside of the school. So this is a model, and it's actually animated. So as it grows, I want to explain it to you. So this is a model of how testing can help break those chains of transmission. So you can see at the beginning, there's this exponential growth in cases, and it just kept getting bigger. But once they introduced a testing, a rapid testing or a routine testing system, you started breaking the chains of transmission so that there were fewer cases. So this is a transmission event is red, and the green, you have a screen test and they're taken out. So if here's one, oops, it's going to restart on me. So the idea being that if you start a testing thing, you're doing it regularly, you're going to catch a case, you're going to make it so that they don't spread to other people. You still have your contact tracing system set up, and they're removed and isolated so that they don't spread to other people. The interesting thing about this, and as you can see over time, the number of cases, you had exponential growth, but the number of cases declined over time. And even when you have an uptick, you can catch it quickly and it continues to decline over time. The interesting thing here is that this model is for 50% participation. You don't actually need 100% of people to participate to see benefit. But that said, the more people who participate, the quicker you can actually decay the curve. So the quicker it goes to zero. So investing in testing, again, investing for testing in Littleton, which, or especially our schools, which are our most dense setting with the longest duration of time that people spend there, may have direct impact on our town as a whole and reduce our case rate, not only for the town as a whole. So that gets into some real life examples. So the thing to keep in mind as we talk about test positivity, and we're talking about the state numbers and like the higher ed examples that we've talked about a little bit, is that it really matters who's being tested, why they're being tested, and how often they're being tested, because that impacts interpretation and usefulness of the metric. So again, test positivity is the number of positive cases, so positive tests divided by the number of tests. I misworded this slide, unfortunately. So let me say this again. So number of positive tests over the total number of tests conducted. It's not a prevalence estimate. So it's not the number of people, it's a number of tests. So, but it matters who's getting the test, why they're getting the test, and how often they get the test. So you can see for the state, the top two lines here are actually the symptomatic or close contact testing system that the majority of the state has access to. This is testing people with known symptoms or who have been a close contact. And because you are purposefully testing people with symptoms or who have a known exposure, you're actually going to end up with a higher test positivity metric number. So in contrast, if you do routine testing on an ongoing basis of, for example, the higher ed college testing of student and staff, regardless of whether they have symptoms or have had a known exposure, then you are going to capture the asymptomatic cases earlier, and you're going to cut their lines of transmission because you're going to isolate them. They're going to have less opportunity to transmit to other people, and you can keep it really low. Now, the other part of the reason this is really low and less than 1 is because your denominator is bigger. You're doing more tests more frequently. So the proportion of people who are positive is much lower because you have just a bigger pool of tests. So, and let me just check my numbers real quick. So this kind of higher educational surveillance testing program, colleges are using them. Again, I said they identify cases early in the transmission cycle. They have really strong, they pair it with strong isolation policies, test, trace, and isolate policies so that they prevent spread from other people. So I know that colleges in Massachusetts, I have to say Massachusetts kind of had this set standard that they asked the colleges and universities to really rise to. And we've been really lucky because we've seen a number of universities or colleges in Massachusetts have an outbreak and they clamp right down on it. Some of them increase testing, number of tests done or frequency of tests done to really just clamp down and stop the spread from happening quickly. So this kind of higher ed testing system, it's not just school settings I would work for. We see examples with the U.S. Armed Forces. We see examples with pro sports and businesses that use it just to keep their operations running too. So the big thing is these two testing systems, symptomatic close contact testing and higher ed testing, are set up for two very different reasons. And the test positivity and the results will be very different because they had two different intentions. So they actually should not be directly compared. You shouldn't say that, you know, there's 0.5% in higher ed testing, 0.5% of tests are positive in higher ed testing, but 6.2% compared to 6.2% in the state as a whole, because those are actually two very different reasons for testing. So what you can look at is week over week, the changes in time. And you can see that week over week, you've kept college and higher ed testing pretty steady. And where there is an increase, you can clamp right back down on it. Whereas when you're doing symptomatic testing, kind of when you're missing those asymptomatic trends, you're kind of still always playing catch up. And it's more variable, and you're seeing the higher proportion of tests that are positive. So again, I think if we end up with a testing program here in Littleton, people will be very tempted to say testing in their school is less than 1%. We should just open up, but you can't compare that to the town as a whole, which is 5%. It's just, that's not how it works. So this is a real life example. This is Boston College testing experience. They So it is my understanding, based on the information on their website and from news reports, that they started out with an entry testing for all students and staff. So that was the first 2 weeks or middle of August and the last week in August. And then after that, they switched to symptomatic testing for students and staff. And then, so that's why these are red there. That's that first initial bolus of people, and then also symptomatic testing. And then in the middle of September, there was actually an outbreak of 73 cases, but they had only measured 2,900 tests. So that was a test positivity of 2.5%. So after that outbreak, the city and state officials, including the DPH, requested that Boston College increase testing capacity and also transfer their contact tracing responsibilities to city officials. And so you can see that it took them a couple of weeks to double their testing, more than double their testing, but then they stayed pretty high up until the week before Thanksgiving. This is when the governors asked them to test everyone before they sent them home for Thanksgiving. So that's the reason that number jumped up again. So in the middle of September, BC switched to a surveillance testing approach for the remainder of the semester. And while there still happened to be cases that arose, there was no outbreak that happened. They could trace, isolate those individuals, and it broke those chains of transmission. So the test positivity for the remainder of the semester was less than 1%. So I just want to end by kind of reviewing the benefits of pooled testing. So the first is, like I've talked about, is to reduce spread by identifying cases early, often before they realize they are sick. So pooled testing results are also available in less time than the current weekly metrics that I present to you guys each week, which are less targeted for the populations we're worried about here in town. And also, we would end up knowing more about the population we're testing because we're purposefully putting a testing program into place. It's also a direct measure about what is or is not happening in Littleton Public Schools in our current hybrid model, so we can see how well we're doing. And should there be a cluster event, the schools could apply a focused mitigation effort, such as quarantining just a classroom or an individual or a few individuals or school if it really got that bad. So it helps them focus who needs to be sent to remote school for a couple of weeks for other mitigation efforts that need to happen. And then also the baseline data that you might get from the start of a testing program really can help inform future data-driven decisions regarding in-person instruction, or if other mitigation strategies are changed, so that you can keep ongoing look at like what did we change and what happened over time. So again, this really helps inform data-driven decisions for our town, not just in the schools, but also for the town as a whole. And that's all I have tonight.
That is a lot.
Yeah.
Anybody from the board have any comments?
Thank you for the information. It was very nice. Thank you.
Thanks, Dina.
Go ahead, Mike.
I think I'm stating the obvious. The take-home message here is in my view, we ought to encourage the town and the school committee to think of this as not whether or not to do surveillance testing as soon as possible, but to do it and make a choice rather quickly. And I would say it's gotten greater urgency because the variant which has appeared in the population in Massachusetts and elsewhere is considerably more contagious than I'll call the original virus. And I'd also like to point out, the longer we wait for vaccine, and I realize it's unknown. I realize that we don't know when the population will get the vaccine. The longer we wait, the probability of more variants of the virus emerging go up. This virus, or this belongs to a family where the longer you wait or the longer you give it a chance to mess around, just simply because of its reproductive rate, and that's how it evolves, the more likely you are to see variants. Now, not all of them are successful, but all you need is one or two more. And then obviously we want to avoid the situation where we wait so long that one of the variants basically can, as it were, not completely escape, but basically make some of the vaccines less effective. So given the fact that the bulk of the school population and also the population in town are not going to see a vaccine for quite a while, I think it's very important that that means forced waiting that for the vaccine, that we should start taking more, shall we say, aggressive action to unblind ourselves to what's going on. So a good place to start is the schools. And I think at that point, the town can then take the first step in actually getting used to the idea of tracking what's really going on. Because we can't wait for the vaccine to reach our population in sufficient numbers to get the full benefits of its protection. So it's not, let me just repeat, it's not a question of if, it's which one and how soon.
Louise or Kevin, do you guys have any questions for Katrina?
Just want to say, Mike, that was really well said. But I actually just have a question for Jim, if he's still there.
Yes.
I was wondering, what's your opinion of testing within our public schools? What's your take on that?
So again, our nurses work closely with the school nurses in all the district, and I haven't talked to that, to her and the other nurses about what they're seeing for school transmission. But the school nurses in all of the schools have been incredible with kind of identifying and sending kids home. So the actual transmission within the school building, in combination with all of the other mitigation methods, the distancing and whatnot, seems to be working well in the school system. So I don't know that we've seen, and we certainly haven't seen much of what we would consider in-school transmission. As soon as somebody's identified, the contact tracing happens. Like I said, the school nurses are all over it. I think with a testing program, it's really important to go at it with a plan. What is it we're trying to achieve? How do we want to message it? What are we going to do when we get the results? Whatever results they may be, so that you can use those results and be able to explain that to people. Because if you set something up and you set metrics up, you need to be prepared to do the things that those metrics would lead you to. So that would be the only thing I would suggest at this point.
Let me just add the other piece of this, Kevin, is that, and others, that if we had a surveillance testing in the school system in the schools, the choices that parents can make, and I'm sort of biased about the K through, I'll be arbitrary, 7th grade, because from the very beginning, I can remember the discussions that I had and reported to this board several months ago, that one of the biggest silent victims of this pandemic are going to be young school children in K through, let's say 7, who do not, for very good reasons, their parents decide it's not safe enough or it isn't objectively safe enough for them to be in school. They're the ones who are going to suffer the most, because that's long-term and very difficult to recover that developmental time for growth and development. Now, I'm not saying that people who are in 7th grade and up aren't suffering, please. It's just that the damage is documented. It's quite severe on little ones who don't have an opportunity to have the social and educational and stimulation of being around other kids and adults other than their parents and grandparents. And that's what the school offers. And then the third and obvious thing is that having a testing program means that parents can start making decisions along with the school about capacity of number of children who can be in the building at a time. So the mitigation efforts can be, shall we say, modulated according to need, as opposed to let's do this because that's what's in the book and hope for the best.
Thanks, Mike.
Well, I guess sort of as a follow-up, Jim, in regards to the asymptomatic cases, I mean, I know we're handling the symptomatic cases very well, but in regards to trying to get a bigger population in the schools and implement some sort of asymptomatic testing, some surveillance testing, do you think that would be beneficial?
I think always having a better handle on what's happening in the school is a good thing to do. I haven't seen a lot of results from this testing. I know the town of Harvard started it. I think they did their first round of testing. I don't know the numbers from those results yet. But again, when you look at where the clusters are in the state, and again, clusters defined by 2 or more cases at a particular location, households seem to be that. So, you know, if a parent is bringing in or somebody older is bringing it into the household, if that asymptomatic person is going to school and you're picking it up and sending them home, that might be a benefit to you.
Thank you.
So I know Anthony and I think Justin is in the audience. Katrina, are you going to be presenting this information about pool testing to the school committee at all?
I will definitely share it with them. I don't believe they have a school committee meeting tomorrow. I could be wrong.
So I don't know if Anthony and Justin have any questions that Katrina can answer about pool testing.
I'm okay. I'm all set. Thank you. Katrina, I'll see you Monday, right? Anyways?
Yes,
All
I will
right,
be there.
great. Thank you.
Great. Justin McCarthy, did you have anything you wanted to ask Katrina? Dave, I don't know if you can let him in. He's got his hand raised. Justin's on the school committee.
I don't know if you can.
We can hear you, Justin.
Oh, okay, great.
Nope. You're muted again.
There we go. Is that better?
Yeah.
Great. Not used to being on the other side of this. I suppose my question is, what's happening at BC, for example, if I was to follow that case study, is very different than what's happening in Littleton grades K through 12, because we don't have a dormitory setting within our school. We don't have students that aren't surrounded by guardians, hopefully monitoring what's taking place after school hours, weekends. So, well, I think there's some value in administering a testing program within the town. I'm just not sure that the most effective way to do that is to ask the school system to do that on behalf of the town, because the town, the transmission rate within the school system is very low because of all of the other layers of Swiss cheese that we're using and all of the deterrents for transmission. So I'm just wondering if Jim or Katrina or somebody else might be able to comment on how higher education is very different than lower education. And do they agree with that statement? Do they disagree with that statement? Is there any additional thoughts around that?
I've looked into it. I think Katrina has as well. But I think you're missing the point. I think what Katrina was trying to get at, or what I look at when I look at colleges and universities, because in all fairness, the colleges and universities, they put in, and I would use Harvard as a more extreme example, because at the moment they have a very, very low incidence, in other words, reduced number of cases that ever erupt in that place among their entire population, which comes very close to being pretty close to big as we are. The difference is that most of the students are basically either sequestered in their rooms doing virtual learning, and then the next semester they're sent home where they're sequestered at home and have to be at home, while another group comes in and does virtual learning in the dormitories. So it's comparing apples and turnips. So the point I believe that best be made is the reason this program, however rigorous it is successful, is not because of the, quote, draconian measures to make sure that nobody sees anybody else who goes home and does everything virtual. It's the value of the testing to know that it's working or not, that what you're doing is working or not. Mm-hmm. We have absolutely no way of knowing. And I think Katrina made this point, and indirectly so did Jim. And that is that if we are getting, as Jim suggests, and we don't know this, if we do have clusters that are, or we'll call them family events, that result in spreading, we have no way of knowing whether or not it's happening or not going into the schools. And I like to point out to you, the population in the school consists of teachers and everyone else who keeps the school system going. So, and the other piece I'll just reemphasize is that we are not done with this by any stretch of the imagination. That new variant, don't kid yourself. If you think we've seen a difficulty before, this new variant presents a real challenge just on pure numbers. And remember, we won't see a vaccine. So, just for fun, if you want to do some of the projections that I know are going on, just take the number of incidents that we're seeing now with our current layers of cheese and multiply them by at least 2 to 4. And you might get an idea of how a jump in incidence will occur. So that means deaths, that means long-term effects. So from my point, Justin, to summarize, the point of the higher education model is not whether or not dormitories are equal to a first grade classroom. It's whether or not testing, surveillance testing, assists and drives the control of the spread. And the answer is yes.
Justin, I'll add, and I know you and I have had discussions about this. I want my kids in school and in person as much as they can. They're just happier people. They're more focused learners. There's a lot of benefit they're having to being in the building. I actually chose BC as the example simply because they weren't Harvard, who was doing everything virtually. BC was doing in-person learning. And granted, their at-home and off-hour setting is definitely not what we're necessarily seeing here in Littleton. But if you think about age of high schoolers and their social patterns, and even middle schoolers, they more resemble a college age person than they do a younger, lower elementary school person. So I did have some thought about that, picking a college that had in-person learning as an example of keeping it open when you have a surveillance testing program. The other piece, because I'm passionate about keeping our schools open as much as we can. And we've both sat into these school committee meetings and we've listened to people who are asking for more in-person learning time. And without actually knowing what is happening, a measured way of knowing what is happening in the schools or is not happening in the schools, we don't know yet because we're not measuring it. Then I have a hard time seeing how you guys can make data-driven decisions about, well, can we reduce the 6 feet to 3 feet? To get more people in the building? Or can we, just what decisions you're making in order to get more people in the building? Because if without more data, it's hard for me to imagine how you guys are going to be able to maybe open up more in-person time, which is something we've both heard that our fellow parents want. So, and I know that, remote learning days aren't working for everyone. So the more time we can get kids in the building safely, the better will be. And this variant that Michael's talking about is the UK variant it's in Boston. We know it's spreading. It is predicted to be the dominant variant in just a couple months. And it's seemingly more contagious in kids. So if we can get a testing program happening in kids now, we can see where these chains of transmission are happening, which will also break the chains of transmission, hopefully in households or at least to the community. So I see importance of this for disrupting those chains of transmission, not only for the schools and protecting schools for the long term, given this new variant, but also for opening up, hopefully, education opportunities as we go forward the rest of this school year and next school year.
Thank you very much, both of you, for your follow-up on my questions. I appreciate that.
Go ahead, Kevin.
Lisa, this question is probably for you and potentially Anthony as well. I think we're tasked with protecting public health and also the mental health of our residents and kids being in school is a big piece of it. What are we able to do as far as requesting CARES Act money to implement such a testing program, to not solely put it on the school committee and the public schools here, but have the Board of Health actually request those funds and get this program implemented?
Anthony, can you answer that?
So it's Kevin, the second round of CARES money did dedicate some money to schools. I'm not sure what Littleton is going to get as part of that. I'm not sure the schools know what they're going to get yet. We have talked about pool testing, and Mike Fontanella was going to work on it. He was kind of taking the lead. So, when we first discussed, there was never a question of money with public health. Even if we didn't have CARES money, and that's something that the community wanted to do, then we'll figure out a way to do it. But right now it's really in the school department's hands. So I'm just waiting to hear back from Chairman Fontanella to see what he may need from us to support him.
And if there's
Support
anything
the
the
committee.
health can do, I'm sure that, we'd be happy to, try and do the paperwork.
Right. And I think that we're all in agreement that a program would be helpful, very helpful in the schools. And if we can throw our support around it, behind it, Anthony, would that help Mike, Chairman Fontanella?
I will, I'm going to make a note. I'm going to reach out to Mike after this phone call, this meeting, and
Okay.
all right.
Yeah. Because I think like Mike Belden was saying, testing program is going to take a little while to implement, and in that time that we're waiting for it to implement, we're just missing cases that could potentially, shut your schools down, or shut our schools down.
Yeah.
Right.
Cool.
We want to get more kids in, not go in the other direction.
Right.
So I think if you need something in writing with us all, giving our support to it, I think I'm speaking for the board, but I think we're all kind of in agreement that this is something that we need and should have in place. So.
Yeah, I understand, and I'm sure Justin can also pass that message back as well.
All right. Thanks, guys.
Thank you.
Thanks. All right. Any other questions regarding pooled testing? Is there anybody in the audience that, before we move on to Corey and Dave, Corey and Kevin are here with updates maybe? Corey, did you have questions or comments about the testing?
No, I'm just here in support mostly of the school committee and of the Board of Health. So I'm just doing some behind the scenes work to try to wrangle together as much information as I can in an effort to provide that to the school committee and to the Board of Health. So if folks have specific questions, I'm happy to help.
Okay, excellent.
And this is Kevin. I have no major updates on the exposure notification stuff where Kevin Baker and I are looking to reach out to our Michael Hugo person just to get an update from him. But I have nothing that I can publicly share right at the moment.
Okay.
Other than it's coming.
Dave, is there anybody with their hands raised at all?
Yes, Sarah has her hand raised.
Okay, Sarah, can you state your name and address, please?
Unmute. Hi, can you hear me?
We can.
Sarah
How are you?
Good, how are you? Sarah
Good.
Trajankowski, I'm Harvard Road in Littleton. The only thing I just want to bring up about the pool testing is I have little guys. I have a kindergartner and a second grader. And when this goes to the school, if it does, is making sure that there's support for the kids of getting the testing done. My sons are really nervous about getting the testing, like the physical test done, and the implications of what that means if they are positive or anything like that. So just some social emotional support about going over this, especially with the little guys. But I can definitely bring it up to the school committee if it goes through, but I just wanted to make sure that that was being brought on all fronts with it.
Yeah, I think, and I don't know all the specifics, but at least one of the tests is take home. Am I correct?
I did listen to the schools committee last week, and that was the saliva test, but the state one is the nose
The nasal
one.
swab.
Yeah, is the nasal swab. And obviously no one had made any decisions on which way it was going because it's still too early. But when they were getting tested, they're just concerned. Both my parents have medical issues and they're like, Mom, if I get test positive, am I going to kill grandma and grandpa? So it's that even, so that's a concern that I have with it. And it shouldn't be something that discourages it, but it's just something that as a Board of Health, there's a mental piece of this testing with families that have done their best of not being out there and the nervousness of getting tested, even if they're not sick.
Right. I guess we can talk about that once they decide which,
Yeah.
hopefully decide on which one they're going to go with.
Yeah. And as I said, I would probably put my kids in the pool testing because I do agree with the data. I, agree with that, all that stuff, but just so that like they would do something else. But thank you guys. Thanks for everything. Thanks for the updates. I really appreciate it.
Thanks. You guys think that if there's any way that we can get, can we get the public's support behind this too? Do you think that a letter to the school committee on behalf from different residents supporting it, do you think that might help? Just testing in general?
I think it will help. Yes.
Yeah. So Sarah, if you're still on, if you want to write a letter and have support, I guess that might help. Maybe get some of your other mom friends and dad friends to do that too. That might help.
Yeah, let me urge any resident who has got kids in the school system
to support,
get as many friends as possible and put together lots of letters.
Right.
Yeah. I would inundate the school committee and the superintendent's office with a demand that you have testing.
Right.
It's not, please do it. It should be a demand. As a parent, I think you're on to something, Sarah.
You might save a life.
Many. All right. Any other hands up, Dave?
No.
Okay. All right. Any other comments on the COVID update, anybody?
So far, so good.
Okay. Anybody have any correspondence that we'll move on? So any correspondence that anybody's received that they need to discuss?
I can't call it correspondence because none of the phone people, the people who call me on this, are willing to leave their names or want to be identified. So I don't know what to do with it, but there is it's at least 4 complaints, all separated, but all focusing on weekends at a certain, I'll call it restaurant takeout location at King and Great Road on the corner. And apparently on weekends, even though there are setups for plastic dividers, and there are 2 well-masked people waiting on tables, there are as many as 8 to 10 people at each table during the weekend evenings. And interesting enough, all the calls came from when I asked this question, since I live very close to the site, was, were you by any chance going there for takeout? And the answer is yes. And apparently it's the takeout folks who are picking up on this. So I don't know what to do with it because it's anonymous. It's not, strictly speaking, a kind of complaint that goes through our system. And asking Jim to walk in casually into that setting on a weekend is that really a good use of his time? Is there another way to do it? A letter just reminding other restaurants, other food service centers in Littleton to adhere to the occupancy rules. I do understand the pressure on all the owners of restaurants and food service places. This is not trivial.
So Mike, if I might, Lisa.
Yeah, go ahead, Jim.
The state has, when they put all of the sector-specific workplace standards, they didn't have boards of health do inspections up front. They had boards do it by complaint. And so I'm happy to take that address. I'm sitting here trying to think of the location, but if you want to give me that, I'm more than happy to go in and start with education. The state has this escalating enforcement process where they ask you to go in and say, hey, look, these are the complaints we're receiving, address it, make sure they understand. If that doesn't work, go in and put it in writing. So I'm willing to start that process if you want to shoot me an
Sure,
email with particulars.
and I like your approach. The soft touch would be would be appropriate. I'll make sure you get the address.
Thank you.
And thank you.
Yep.
Great. You know what? I've got an unlisted phone number, but my answering machine is full. I wonder if I'm getting phone calls too. I better delete some messages, see what's going on. All right. Anybody else have any questions or correspondence or anything like that? Okay, so we'll move on to the minutes of January 13th of 2021. Does anybody want to make a motion to approve those minutes?
I'll make a motion to approve the minutes of January 13th, 2021.
Second.
Great, thank you. So Kevin, we'll do a roll call. Kevin Baker,
Baker, yes.
Gino Fratelloni,
Gino, yes.
Louise Nichols,
Louise Nichols, yes.
Sheldon,
Mike Sheldon, yes.
and Lisa Flanagan, yes. So the minutes are approved for the 13th of January, 2021. Member comments? Anybody? I just want to thank Jim and Katrina and Corey and Dave.
Yeah.
Sorry, I keep calling you Dave, and Kevin Davis too for showing up like us every Wednesday with all this great information. And frustrating as it is, but great information. So my member comment. So
I really appreciate Katrina's explanation of the testing.
yeah, great. Okay, and move on to public comments. Dave, is there anybody with their hands raised?
We have a hand, John.
Okay, John, state your name and address, please.
It's John Kurzwick, 171 Hartwell. I did send a couple of notes over to the board. I don't know if they got a chance to read those. One of them was related to actually the test positivity, and it actually did come up in tonight's meeting in the presentation, and I wanted to get that over to Ms. Hagberg, but I don't have her contact information. So I'd request that somebody forward that over to her so she can see that. But it directly goes to some of the questions about prevalence in the schools, whether it's K through 12 or college. I did some rough estimates, and the case prevalence rates look very similar. Now, even those are somewhat flawed estimates, but I do believe they're better than looking at the test positivity. And I think she tried to address that somewhat in her presentation, but I think people should consider that before saying that the testing is saving things. The other letter I sent over was actually more geared towards Mr. Zeldin, and this kind of goes to the question of when is this all going to end? The LA Times, they just wrote a story that they said LA County had 33% infections total. So it seems like an epidemiology 101 is to figure out how many people within the community have already been exposed to COVID-19, because if we're talking 50% of the community has already been exposed, I think that would be an indicator to say, okay, maybe we can start relaxing some of this stuff. And relative to that new variant, the UK variant, I'd be very cautious about that one. The people that wrote that paper, one of them was the famous Neil Ferguson. He's on that paper from Imperial College. You'll recall he's the same gentleman that said 2.2 million people would die in the US in 4 months. So I would tamp that down, because if you look at the growth rates for deaths in this season, they are 7 times lower than they were during March, April, and May. So it's not all gloom and doom. Things are looking up. Yes, cases are up, but I think Katrina showed well that the hospitalizations are flat. ICU is 30% lower than it was in May. So, one of the things I'll send another letter over to you guys, but I would appreciate that maybe you guys consider putting some of this information I send over in the weekly update, because it's not all gloom and doom. There are things that are much better than they were in March, April, and May, and I think we should recognize that because people are hurting. They've been out of work for a long time. They've been out of school for a long time, and we have to make sure that we have the right metrics, and we're looking at the right metrics, because if we don't have the right metrics, we're going to be making a lot of bad decisions. So that's just my input for tonight, and I appreciate the time. Thank you.
All right, thanks, John. Anybody else? Dave?
I don't see any other hands.
Okay. Shall we call it a night? Anybody else have any comments to say?
I make a motion to adjourn.
Second.
Okay, we'll take a roll call. Kevin
Thank
Baker,
Thank you so much.
Gino Carloni,
Yes, Gino.
Louise Nichols,
Louise Nichols, yes.
Mike Zeldin,
Mike Sheldon, yes.
yes, and Lisa Flanagan, yes. Okay.
Thanks, guys.
Oh, actually,
Thanks, everyone.
actually, we forgot to, next meeting will be next Wednesday. And I actually, before Jim leaves too, Jim, do you need me at that meeting tomorrow night? You still there, Jim?
He's muted.
So what we need to, for Neshoba, what we need to do is have 5 towns available.
Okay.
For quorum. So if you can be there, that'd be great. I don't know who else coming. I never know until they show. So.
Okay.
I know at least 4 will be there. So.
And what time do you think you need me there?
So our meeting starts at 7.
Yeah. And is on the agenda, do you need me there that whole time?
So we need to have, it's budget meeting. So, obviously we want to make sure we have quorum so we can do the budget. And the budget will come probably, I don't know, probably 20 minutes in. I'll do a COVID update for the entire board. And probably 20 minutes in, we'll be doing budgets for the public health, nursing, and the environmental division.
Okay. All right. On the back of the second and the back of that first page.
Yep.
All right. And what do you need me to do? Just be there?
You're a voting member, you're a board. You get to decide, is this the right thing we're doing? So we'll have our CFO do the presentation of the budget and available to ask any questions that you have.
All right. Okay. Sorry to take our time with that. Yeah, I'll see you tomorrow night around 7. And I do think with, like Mike has said, the variants, strains, the testing that we're trying to get the schools to do, I think still we got to meet every Wednesday. Is that all right with everybody?
Yeah.
Okay.
And then I think next Wednesday we might, if there's anything, I think Janet's trying to alternate the public hearings. So this week was just the COVID update. We might have some public hearings. So, so we'll need that. We'll need those meetings on the other, we still need those meetings. So, all right. Motion's adjourned, meeting's adjourned.